Hi, everybody. I guess before I get started, I just wanted to thank both LifeBulb as well as the sponsors who are making today's event possible. I want to thank our wonderful team at Temple, with whom it's an honor to work with every single day. And I want to especially thank the donors and the recipients, because this is really all about you guys, and it's an honor to work for you guys every single day. It's really what keeps me coming to work. So today I want to present on managing medications and side effects. Just as a brief self-introduction, as mentioned, my name is Kevin Lee. I'm one of two abdominal organ transplant pharmacists that we have on our team at Temple Hospital, with my counterpart being Adam Diamond. And I think when you hear the word pharmacist, you think about somebody who's behind the counter, kind of filling pills, labeling bottles, and then dispensing medications. But my role with our transplant team is just a little bit different. I offer both a lot of clinical consultation, so offering up-to-date understanding of all of the complex medication regimens and data that goes into managing patients' medication regimens, and then helping us make the best data-driven decisions every day for our patients. So I may not see you guys every single day, but just rest assured that there is a medication expert who's always with the team, both in the inpatient setting as well as the outpatient setting, reviewing your labs and helping drive those decisions. So what I really want to get into, and I think a couple of other speakers have really touched on this, is that there are a lot of medications after transplant. So this is just a sample medication list up here on the screen, and these are just the transplant-specific medications. This doesn't include anything else that you might be on for managing your blood pressure, managing your cholesterol, all of those other things. And the list can get kind of intimidating, right? So to make those doses up, for example, of extended release tacrolimus, which you take once a day, you would need to take at least 4 pills with that morning dose. And then it would be another 2 pills, both in the morning and the evening, to make your dose of mycophenolate, an additional dose of prednisone, and then the sulfamethoxazole trimethoprim, as well as valganciclovir. Not every center, such as ourselves, will give patients antifungal prophylaxis with nystatin, but I just wanted to include it to illustrate that, and I'm sure our recipients are really well aware, the medication burden can be a little bit overwhelming, along with all the other things that you're already dealing with, recovering from surgery, just trying to get feeling, back to normal. So just briefly, what are these medications really for? I think we've already talked about this a couple times today, but with the tacrolimus, mycophenolate, and prednisone, they're to prevent rejection of the transplanted organ by your immune system. So we really need to weaken your immune system so that it doesn't detect the transplant, right, which it recognizes as a foreign object and begin to attack it. And with that suppression of your immune system, there's an increased risk for infection, especially within that early period post-transplant. So we do need to give you these other therapies on the bottom of the slide in order to prevent common infections that happen while your immune system is at its weakest. So what kind of expectations do we have with the medications? And this is something that I coach our potential transplant recipients through when I'm doing their evaluations. These medications do require a strict dosing schedule, so they really do need to be taken every 12 to 24 hours with as little leeway as possible. And some of that is because, as Dom mentioned with her one question, we need to monitor blood levels of one of the medications, tacrolimus, right, to make sure that those levels aren't too low and we're risking rejection, but those levels aren't also too high, and then we're over-immunosuppressing you and we're really risking a severe infection. These medications do need to be taken sometimes consistently with or without food, just because that can affect their absorption, which can then affect those previously mentioned levels that we're checking. And because of all of the things that are going on right after surgery, these medications really do need to be adjusted frequently, which means that in that initial month before, for example, at Temple, you get discharged from the surgery clinic to the nephrology clinic, you may have to come in as frequently as 2 to 3 times per week, just so we can make changes to the meds. But luckily, as time goes on, those clinic visits do become less frequent, so they can be spaced out to every couple weeks and then eventually every month, and hopefully at some point to every, say, 3 to 6 months or even a year. So with patients, the one thing that I always coach them on and I always encourage is that they really should be as open as possible with communicating with the transplant team about any kind of medication concerns that they have. So whether it's supply issues or you're having trouble obtaining the medication, you're having insurance issues, copay problems, we want to know right away. in addition, if you feel like your regimen is too complex, you're struggling with, compliance or adherence, we don't want you to take that as a personal failing. We understand that, it's difficult to start almost a new life after going through however many years of dialysis and then being on, say, up to 15 new pills per day. It's really, really overwhelming. So we're here as a resource to help you guys, every single time you come to clinic and you see us. And the focus of this presentation really today is going to be one of the major barriers to taking all of your medications consistently, side effects. So with immunosuppressants, there really are so many side effects. I mean, if you were to look at the actual list of things that are associated with these drugs, you would probably end up with a sheet of paper as long as like a CVS receipt. So my goal is really to focus on the medication side effects that you as patients can actually do something about, that you should be aware of, but just know that there are other side effects that we are keeping an eye out for in the background and helping to manage. I just haven't included them here for the purposes of time. So the first drug that I'm sure most of you are familiar with is tacrolimus, and that comes in 2 different formulations. There's actually a 3rd formulation I haven't posted here. It's just that we only use these 2 at our center. So there's tacrolimus immediate release or Prograf, which is used twice per day, or there's tacrolimus immediate extended release, also known as LCPT, which is used once per day. The first side effect I want to review with tacrolimus is neurotoxicity. So this can really present most commonly as hand tremoring, subtle hand tremoring, usually up to 2 hours after you take your dose. It can also present as tingling, headache, brain fog, that kind of thing. And what I want to emphasize with each of these slides is there are things that you as patients can do, and then there are things that we can do as providers for you to help manage these side effects. Because I want you to feel included as a part of your own care team, right? It really takes a village to take care of a transplant. Pharmacists, physicians, nephrologists, our wonderful coordinators, really everybody, but it also includes you. So the number one thing, like I said, is you should really let us know if or when any kind of symptoms occur. You should also kind of keep track in the back of your mind, when do those symptoms occur? Am I having a persistent tremor throughout the entire day? Or is it right after I take my medication, a couple hours later, I start to notice that my hands are shaking and I'm dropping things or I can't focus through the day? So what we can do as providers for you is we can try and change the dose. This is a dose-related side effect. So if your levels are too high of this medication, then that's when you're going to most commonly experience this side effect. We can try to change formulations. So there is a lower peak with the extended release formulation of this medication. And because that is a peak-related side effect, switching formulations may improve in certain patient populations their incidence of tremor. Or we can try to change the medication entirely from one medication that's in the same drug class to a different medication entirely, which is usually our option of last resort. The next side effect that I want to go through is something that you may end up seeing on your labs, and I'm sure that anyone who's had a transplant knows this pretty well because you end up having to take a bunch of pills for it, and that is electrolyte changes. So tacrolimus is capable of increasing your potassium levels, and it also increases the amount that you waste through your urine of magnesium and phosphorus, right? Which means that patients very frequently after transplant will become hypomagnesiemic or hypophosphatemic. You just have very low levels. So you, as a patient, will meet with our wonderful dietitian, for example, and the rest of our team, and they'll encourage you to try and improve your diet and take in all those things that you couldn't take in before, like with Beth with the Doritos and the Coke. So what we can do as a team, we can provide, supplementation, right? Magnesium tablets, oral phosphate, oral potassium tablets, that kind of thing, infusions in the most severe cases. We can also change around your other medications if these are really severe and persistent, or we can add on other medications for management. For example, temporarily, we can add on medications that bind up the amount of potassium in your food just to make sure that those levels don't get too high. These problems usually resolve once you're outside of the first month of transplant. This is really a set of side effects of tacrolimus. They're known as metabolic side effects, right? And just breaking this down, exposure to tacrolimus and other calcineurin inhibitors over a very long period of time can affect your blood pressure, your blood sugar especially. It has a very high incidence of post-transplant diabetes, and your cholesterol. So as always, we just encourage you to stick to those standard recommendations of diet and exercise, And when it comes especially to your blood pressure and your blood sugar, if you are keeping track of that at home, the more accurate those logs are, the more that lets us know that there's a signal for us to intervene, right? Or manage your insulin regimen or other things that we can do for you in clinic. Really what we can do is we can monitor and adjust these medications as much as possible. As time goes on past transplant, although these medications, the immunosuppressants, are meant to be lifelong, you can take less of those medications over time as your body kind of gets used to the transplant. So being judicious about lowering those levels to a reasonable goal to make sure that we're not overexposing you to the medication and then impacting your long-term health is a big part of a pharmacist's job. GLP-1s are also wonderful agents. We do recommend them later post-transplant. They can just be a little bit difficult to tolerate with the GI side effects that can come with them that we'll talk about later. One of the other side effects, and this is really a cosmetic side effect, but it matters a lot to people, is alopecia or hair loss, which occurs but not so commonly, I shouldn't say. Let me not scare people with tacrolimus, but it is possible for it to happen. So what we can encourage our transplant recipients to do, biotin is very safe and it's available over the counter for them to take. However, we do recommend avoiding other supplements for hair growth until you have the opportunity to discuss them with us in clinic. And that's because some of these supplements, other than biotin, can come with products in them like ashwagandha, which are immunostimulatory. And a lot of patients think about the medications that they're taking and that they get from a pharmacy, but not necessarily the herbal supplements that they're taking, right? Which can also have impacts on your immune system and potentially increase your risk for graft rejection. What we can do is we can switch from tacrolimus to cyclosporin, which has a lower incidence of alopecia. It actually does the opposite, leads to hair growth or hirsutism. Or we can add on these other medications once we've vetted them out, made sure that they're safe for you to take after your transplant. We can include those after discussing with your physician. So the last thing that I'll bring up, and this is always one of my least favorite subjects just because I don't want to ever scare somebody, is that with these medications, and it's really all immunosuppressants, there is a greater incidence of cancer after transplant. And the reason for that is twofold. Your immune system really acts as kind of a sentinel to get rid of bad cells before they're able to replicate and turn into cancer. But some of these medications will also make you more sensitive to sunlight. So what I counsel our patients on prior to transplant is that if you're going to spend a prolonged amount of time in the sun, for example, if you've got a hobby like gardening or you like to go to the beach, we don't want to preclude you from doing those things, but you should take the appropriate precautions to wear sunscreen with at least SPF 30, reapply it as often as you can, and wear protective clothing like long sleeves, hats, etc. I mean, I always tell people if you're going out and just getting the mail or running an errand, don't worry about it as much, right? But if you're going to be out in direct sunlight for 4 to 6 hours, then you should really take care of yourself, just knowing that there is an increased risk. And then prior to transplant, we really do encourage our patients just to memorize or have a good understanding of all of their skin blemishes, moles, beauty marks, that kind of thing, just to know if anything is changing. Do we need to set you up with an appointment with a dermatologist, for example, just in case there is a suspicion that there is something wrong. We do recommend age-appropriate screening for all of our transplant recipients, like for example, a colonoscopy. And as I mentioned, we can connect you with a dermatologist at a Temple practice to screen you. So the last thing I'll cover, and sorry, William, I don't want to infringe on your territory, is that there are certain foods that we want you to avoid after transplant. And that is because they have significant drug interactions with tacrolimus. So the ones that I have listed on the left are not an exhaustive list, but they are the most common. And those would be things like grapefruit, starfruit, pomelo. I have starfruit listed twice there, oops. But really any very large tropical citrus, right? And that is because these medications will actually inhibit the metabolism of the medication, so you won't break it down and excrete it from your body as readily. And those increases in drug levels can lead to an increased risk for side effects. So the blanket recommendation for all of our patients is just to avoid starting any new herbal or dietary supplements before talking to our transplant team. I'm going to move a little quicker here, just in the interest of time, but for mycophenolate, there are 2 products. There's Cellcept or Myfortic. They've been studied and they're pretty much identical in terms of efficacy, but they are both twice-daily medications. So the most important side effect to go through with mycophenolate is just GI upset. Really what you can do is you can let us know at your regular clinic visits, and then if it's severe, if you're having really bad nausea and you can't keep food down, or you're vomiting or having diarrhea, to call your transplant coordinator right away. Don't sit on this kind of thing, just let us know. Some of the things that we can do, we can lower the dose of mycophenolate. We can try and change the formulation from CellCept to Myfortic, which has shown some improvement in those symptoms in other patients. We can change to a different medication in the same class entirely, which again would be an option of last resort. And we also want to try and rule out other medication-induced causes. So this is relatively common early on in transplant, but as time goes on and we find a kind of the dose that works for you, we try to keep you there. But we need to know right away, if there's just anything wrong so that we can help take care of you. One thing I'll bring up is that with mycophenolate, the drug is contraindicated in pregnancy. It's a known teratogen. So just for our younger transplant recipients out there, if you're intending to conceive, then the medication really does need to be held at least 6 weeks prior to starting. And while you're on this medication, you should be on effective birth control. So what can you do? If you are intending to conceive after transplant, just let us know as a team and we can work through pregnancy planning with you. We've done it for several of our recipients thus far. I already mentioned to use multiple forms of contraception. And what can we do? We'll change you to a different medication that's in the same class that is safe in pregnancy. And then if there's any pregnancy that was unexpected, we can report it to a transplant registry, discontinue the medication right away, make sure that we institute the appropriate monitoring and follow-up for you in clinic. So with prednisone or corticosteroids, those are once-a-day medications. The number one thing I hear a complaint about is insomnia or just too much activation. With this medication, it's easy to say improve sleep hygiene. I should probably improve my sleep hygiene. But probably the easiest thing for patients to do is just to take it in the morning, because taking it in the evening leads to a greater incidence of insomnia. We can consider the addition of melatonin that has been shown to improve outcomes for patients with who are taking prednisone and have insomnia. And depending on your risk for rejection and the reason why you received a kidney transplant, you may not need corticosteroid therapy. So we can try to at least minimize the dose where appropriate for you. This is a repeat of the tacrolimus slide, but corticosteroids or prednisone also come with the same kind of metabolic side effects. So all of the things that I said prior will apply here as well. And then the last thing that I want to bring up, this is a very large slide, is just that with the infection prophylaxis or the infection prevention medications, so for example, the Bactrim, the valganciclovir, the nystatin, there are a lot of overlapping side effects, right? So increased potassium in the case of Bactrim, nausea or vomiting in the case of valganciclovir, as well as, this kind of nasty taste in your mouth, as well as nausea with nystatin. So those are also things that we would take into consideration if you let us know that there are any problems during your clinic visit. At this point, I'd be happy to take any questions. I know that is a lot of information. Also available, if you don't feel comfortable asking a question in this setting, I'm always happy to take an email. Hello.
Hello from the online audience. Is there a specific test to measure and track the trough levels of mycophenolate CellCept, just like the FK levels can be tracked by their trough levels?
So that is a wonderful and complex question, and the easiest answer is yes. The downside to that test is that measuring a trough level of mycophenolate only tells you, it's almost like a coin flip, whether it will actually give you an accurate representation of how much total exposure the patient has. So it's really more so useful as a marker for malabsorption or whether the medication is getting where it's supposed to go, as opposed to trying to track clinical outcomes with it. There is an accurate way to track mycophenolate blood levels, but it's very complex. It's called limited sampling strategies, where you need to draw 3 separate blood samples, and from there you can enter into a very complex equation and extrapolate the total amount of exposure that a patient has. That does have some data which is related to early postoperative efficacy, but is only kind of tentatively related to toxicity. So we can draw those blood levels we have in order to check for compliance, or in patients, for example, who have had a gastric bypass and we need to know, are they actually absorbing the medication? But we don't routinely use it to monitor for medication adjustments at each clinic visit.
Thank you.
Yeah, absolutely. Thanks.
Okay, we welcome would you like to speak from here, or would you like
Yeah,
to?
which would make you feel more comfortable.
Yeah.
Okay, I'm going to be seated.
All right, good afternoon, everyone. So again, my name is William Stallings. I'm a dietitian from Temple Hospital. And we as dietitians are involved in all phases of transplant. So we start from the evaluation phase to the post-transplant phase to the post-transplant phase when they're discharged from the hospital. And right now, I'm the only dietitian at Temple that works with the transplant team, so I work with all organ transplants, so heart, liver, lung, kidney pancreas, and also living donor. So hopefully within a couple of weeks, we actually will be hiring a new dietitian for help. But my goal today is to talk about what are the nutrition goals for all three phases. So for the evaluation phase, that's a lot of feedback. So we definitely want to maximize pre-transplant nutritional status to ensure that patients are nutritionally sound prior to surgery. So we want to make sure that, again, that they are well-nourished going into surgery, because we want to make sure that we have the best outcomes after surgery. Another thing we'll also do is promote if they need to gain weight prior to surgery, or if they need to lose weight prior to surgery. Because with the different organs have some BMI cutoff limits. So I can either be too underweight or maybe too overweight for transplant. So we help facilitate that either weight gain or weight loss before transplant within the evaluation phase. So that I talk to patients about what they're eating. I want to look at what you're eating for breakfast, lunch, and dinner. So I get a 24-hour dietary recall, so I want to know what they're eating for breakfast, for lunch, for dinner, what kind of snacks they're having during the day, what they're drinking during the day. Because not only do I want to see if you're adequately nourished going into surgery, but I'm also looking for those type of foods or beverages that could potentially interact with the transplant medicines after surgery, just like Kevin mentioned. So I want to make sure that there's no interactions with the medicines or foods post-transplant. And we also definitely want to make sure that we manage any disease symptoms that the patients may have before transplant. So if they're diabetic before transplant, we want to make sure that they have adequate blood sugar control going into surgery, because obviously that will cause complications after surgery if they're uncontrolled diabetic. So what happens after transplant? So right after transplant, they're still in the hospital, they just received their brand new organ. We go to see them as an inpatient dietitian, and number one, we want to make sure, again, are they able to eat? So if they're able to eat, we'll make sure that we give them all the nutrients that they need so that they can promote wound healing and recovery after surgery. So what happens if they can't eat? Well, they're still living, they still have this, the body still needs nutrients and calories, so they might have to be tube fed temporarily. So we provide recommendations about making sure that they're getting the right nutrients, make sure they get enough calories, enough protein, vitamins and minerals to make sure that they're healing and recovering after surgery. Okay. So within those acute phase goals, we want to make sure that we establish the nutrition piece. So diet versus nutrition support. We want to make sure that we replete their nutrient stores. We also want to minimize any nutrition-related side effects of the immunosuppressions, as Kevin went over, especially if we know that the anti-rejection medications can sometimes spike their potassium levels or drive their magnesium levels or even raise their blood sugars. So we're all involved in that and making sure that we try to help better manage that with their diet. Well, primarily, we just want to make sure that we provide adequate nutrition via calories and protein to make sure, again, number one, that we support the body's ability to heal, help make sure that the body help fight off infections, and want to make sure that we provide adequate calories to make them help get through rehab if that's needed. So what happens after the transplant and they're discharged home? Well, we're still involved with that as well. So we want to make sure they obtain or maintain a healthy weight after transplant. So again, we talk to them about making sure that they have a healthy diet. We look at making sure they're having the right portions of the right foods. There's information about making sure that they follow what's called the plate method, or the Mediterranean style diet or DASH diet, because we know that some of the anti-rejection medications increases the chances of diabetes, heart disease. So we want to make sure again that they're following the right foods and even in the right portions. As Kevin mentioned also in the slide, sometimes their electrolytes can also spike or drop. So we look at their labs on a weekly or a monthly basis and make sure that, again, that they're eating the right foods. Maybe they have to watch some foods that are high in potassium, or make sure that we're giving them a list of foods that are high in magnesium if their magnesium levels are low. And we'll make sure that they're getting enough protein, make sure that they're healing and recovering. Sometimes when patients go through transplants, sometimes their zinc levels could drop because of the diarrhea, sometimes for the anti-rejection medications. And that can sometimes cause taste aversions. So a lot of times I'll hear patients say that things don't taste right. So the one thing that triggers in my mind is that sometimes they may have a zinc deficiency. So I want to see what they're actually eating to make sure again that they're getting all the nutrients, and maybe we need to replete their zinc levels. And again, sometimes that also can happen from the anti-rejection medications. Also, again, we'll just make sure again that they're getting enough protein, reduce fine carbohydrate intake like sugars. Again, especially if they're on immunosuppressants or on insulin after transplant. We want to make sure again that they're better able to manage their blood sugars so that we can prevent complications after transplant, especially when it comes to increased incidence of diabetes. Also want to make sure that they have adequate hydration. Again, optimizing blood sugar levels, making sure that bone mineral density are at therapeutic levels, because sometimes when they're on lifelong steroids, sometimes that can increase the risk of osteoporosis after transplant. And primarily, we also want to make sure that we reduce the risk of foodborne illness. As everyone knows, with the immunosuppressants, their immune function is low, so that increases, unfortunately, their risk of foodborne contamination after transplant. So before transplant, in the evaluation phase, when I get that history of what they're eating, I'm also looking for seeing what they're eating to see if we need to make any changes after transplant, because maybe they like sushi before transplant, or they like to have their steaks medium rare. So those are the kind of things that they will probably have to change after transplant. And those are things that I like to look at and like to see what they're eating before, so that we can make a plan before transplant so that everything is not so foreign after surgery. So they can actually put a plan in place so that everything won't be so foreign to them after transplant. And as far as patients that are living donors, I want to make sure, again, that before transplant in the evaluation phase, that they have a healthy eating lifestyle. Because after transplant, I want to make sure that they're preventing any increased risk for heart disease or hypertension, kidney stones, incidence of diabetes. So I want to make sure what they're eating follows a healthy lifestyle so that we can prevent any of those complications after their living donation. And again, it's all about reinforcing and educating, promoting healthy lifestyle, exercise, and just to make sure that they follow good lifestyle habits. Any questions?
Thank you, William. Finally, we're going to hear from Melissa. Oh, okay.
Sorry, I was a little slow on the question. Do you give the same advice to all recipients by organ, or are the programs specifically designed per individual? It's a few-part question. Is there appropriate counseling and training provided to recipients who are recipients and that are living with other comorbidities like diabetes and heart disease, such as a renal-friendly diet versus a diabetic diet? How do you incorporate all of that?
So that will depend on the patient. So if, say for instance, if a kidney patient received a kidney transplant, so more than likely they probably would not need to have the renal restrictions after transplant. So then it's about making sure that they're eating healthy foods, making sure that they're decreasing their incidence of contracting diabetes after transplant. So I want to make sure that they are eating the right type of foods, the right portions, and the right servings. So it really depends on the organ, and also depends on where they are and how they present it before transplant. But I definitely do try to tailor healthy eating lifestyle, healthy eating habits, depending on the organ that was transplanted.
Thank you so much. Okay, we're going to move to our final talk for today, and it's going to be by Melissa Hess. Would you like to stay there or come up? Come up. And you're going to share your experience, and really as the mother of Aiden Hess, and as the care partner, and talk about resources and empowerment during the transplant process.
First, I want to thank you for having me, also for Temple for asking me to speak. I am very honored to be here. My son Aiden is the youngest of 4 children, and back when he was 4 years old, he was diagnosed with a chronic kidney disease. Came out of the blue, didn't expect it. It was 2009, that I have to say was the worst day of our lives. So again, at age 4, he was showing signs of blood in his urine. And when I say showing signs, we are talking his urine was red. It was bad. We took him to the pediatrician, did not see the regular pediatrician. We saw somebody else, wasn't used to it. The man looked at me, said, you know, oh, he's okay. I said, no, he's not okay. I said, do you think that this is fruit juice? He said, well, yeah, food coloring. And I said, no. I said, I don't give my children any fruit juices because of a history of diabetes in our family. So he sent us along our way. About a week later, called, got in with his regular pediatrician. That regular pediatrician, you know, knew us, thought, yeah, there's definitely something wrong here. So we took him to have a kidney ultrasound. I had taken him to Lehigh Valley Hospital, up where we live in the Lehigh Valley. He had this kidney ultrasound done, and before Aiden and I left the hospital, the pediatrician was on the phone with me stating that he needed to see a pediatric nephrologist immediately. My mother had kidney issues, so I called his office right away, and I said, I need help. My 4-year-old has this, what do I do? He said, I just saw this guy about a week ago. I was in with a talk. He's at a St. Christopher's Hospital in Philadelphia. I will give you his name. Gave me his name, called him, got in with that gentleman. That gentleman's name was Dr. Jonathan Heilitzer. Dr. Heilitzer went and he made an appointment with us. We saw him probably 2-3 times. And then Dr. Heilitzer noticed his numbers were really not improving. So we said, you gotta come down to St. Christopher's Hospital for a kidney biopsy. He said, it'll be an overnight procedure. You'll come in, we'll do it, you'll be home the next day. We went in, and I I was shocked because the hospital says to me, don't leave. You're not allowed to leave. And I said, what do you mean leave? People drop their kids off and they go home. They leave. I said, you're not going to be able to get us out of here. I said, we're staying here. So he had the biopsy. At that time, didn't know where we were going to stay that night. So my niece said to me, you know, Mom, you know, Aunt Missy, you should really look into the Ronald McDonald House, which was right across the parking lot from St. Christopher's, front in Erie. So I'm like, well, no, that's for people that really need it. We're only here one night. I can handle this. She said, I think you should go there. So my husband stayed at the hospital. I went over to St. Christopher, or over to the Ronald McDonald House. Praise God, they were able to get us in. My husband called, said he's out of surgery. We're in a room. This is the room. Okay. So I went to the room, walked in the room. There's 4 beds. There's a nurse. And I'm looking around. My husband's nowhere to be seen. My kid's nowhere to be seen. And the nurse looked at me and said, who are you looking for? I said, well, I'm looking for Aiden Hess. She said, he's right here. My little skinny child that I brought in looked like a blueberry. He was blown up. I didn't recognize him, broke down in tears. I couldn't believe this was happening. Spent the night. Next day, Dr. Heilitzer said to us, we need you to come to, I want to take you to a separate room. Took us to a separate room. He said, your son has IgA nephropathy, which was brought on by rapidly progressive glomerular nephritis. And my first reaction was, thank God it's not cancer. And the man looked at me in the face and said, cancer would have been better. Wow. Another punch in the gut. He said, this is the most terrible case. I'm not quite sure what to do. We're going to have to monitor him. At that time, Aiden was experiencing stroke-like blood pressures. And a one-night visit, or overnight, turned out to be 28 days. We were there 28 days, and the doctor was treating him for this horrible disease. He didn't know what to do with him. He went and he actually put his case out on the internet. And thank God for the internet at that time, because again, 2009, we're just getting into the internet. A doctor from England chimed in and said, hey, try this. Maybe this will work. And that's really how we learned, because our doctor didn't know what to do. I want to also mention advocacy, advocacy, advocacy. You have to speak up. The greasy wheel gets oiled, and I'm that mom. I'm that mom. And I've learned now, after all these years, my son is now 21 years old, and it's been a long road. He was 4, he was turning 5. I had already thought he's a boy when he was born. I said to my husband, we're not sending him to school at 6 or at 5. We're going to hold him till he was 6. So he stayed home with us. He had, he ended up having Cytoxin infusions, which that was a chemo drug. That's what they said would, and the doctor was good at telling us, so how he explained this RPGN was, he said, imagine a car, and you're trying to go 60 miles an hour in second gear. Not gonna work. It's just not gonna work. So we have to try to, bring that down. So he said, we gotta watch his blood pressures. Can't leave the hospital till we make sure he won't stroke out. They watched the blood in the urine. The doctor actually had the pee cups in the window and watched it go down because he wanted to make sure he saw for himself. So that was the what they were going to do was they were going to give him 6 months of Cytoxan, which is a chemo drug, to try to, as the doctor said, put the monster in the box. That was the whole idea, was just to try to get a handle on things. In February, he ended up having a second biopsy performed, and that showed that the disease had slowed down, but it was still active. And what were they going to do? So the doctor came up to us and he said, look, he said, this hasn't been tried, he said, but we don't know what to do. He said, we're going to, with your permission, give him a drug called rituximab, again, another chemo drug. He said, however, we don't know what the side effects of this are. He said, this could sterilize him for life. We don't know. At that point, do you care? We said, let's do it. I'll never forget sitting in that chair watching that drip going into his body and just wondering, A, is it going to work? And B, what's it going to do to him in the future? We didn't know, but it was okay. We relied on our faith, and that is what I want to get out there too. Faith, faith, faith. In the faithless world that we live in today, first of all, there are good people out there, A. B, you have to have faith. And that's what we did. At that time, we did. We had this faith. We knew that whatever was going to happen, God was going to take care of him. God was going to take care of us. Now, again, I told you, I'm a mother of 4. I had 3 other kids at home. At that point, what do we do with the 3 kids at home? That's where family. You rely on your family. You rely on your friends. You ask for help. And you let people help. And that's difficult for me sometimes because but that's what you do. You say thank you and you ask for the help that you need. Living with IgA nephropathy. I put all these up there because you know what? We lived. We continued to live. We did things. We enjoyed family. We love family. We love friends. Through the whole thing, Aiden sang in the choir. He tried his hand at baseball. He went to Boy Scout camp. We visited Hershey Park. He was the recipient of a Make-A-Wish. We went to Florida for his Make-A-Wish trip. At the time, that was also the last shuttle launch that was happening. And my husband had written to the astronauts to see if we could get tickets to see the last shuttle launch. And actually, Colonel Rex Walheim invited us as his guest to see the last shuttle launch, which was amazing. Had nothing to do with Make-A-Wish. That was my husband's going out and just saying, hey, we're going to be down there. Can we? And that was a phenomenal experience. It was wonderful. We actually made that like a month vacation just to bring some normalcy to my son's life and our other 3 children. More fun. Again, we are from the Lehigh Valley, so we got Phantoms. We're a Wildwood family. We go to Wildwood every year. We would go to Wildwood. My son is a big fan of mountain men, and he loves this Eustace Conway. I don't know who the heck this guy is. He asked to go meet this guy. He met Eustace Conway. Now him and Eustace are BFFs. In fact, we went and we dropped Aiden off in the middle of the mountains of North Carolina, and he spent a month. Yeah, he spent 1 month with Eustace. And I wanted him to experience all that life had to give. I didn't want the disease to keep him. He was good. He was feeling okay. He was controlled. Okay? So Dr. Heilitzer had eventually, he gave us the news that he was leaving St. Chris's. Killed me. What are we going to do? The doctor told us that back when he was diagnosed, he said he's going to need a kidney. Eventually, he will need a kidney. And my biggest thing was dialysis. I don't want my kid to go on dialysis. No. He said, I promise you, I will transplant him before then. Again, Dr. Heilitzer's leaving. Through our faith, through prayer, we had him prayed over. We are Roman Catholics. I took him to prayer services. We prayed. By the miracles from above, Aiden's kidneys grew. We didn't understand how. The rituximab, did help that it put the monster in the box, so he was considered clinical remission for years. All through grade school, middle school, high school, he was in clinical remission. We stuck with St. Chris's for a little bit. Then we ended up trying him at, I took him to, we went to Montefiore, and then we ended up at CHOP because I couldn't do the drive to Montefiore. That was just difficult. So we went to CHOP, and he was seen by a doctor there, but I just don't think that they understood the complexity of his disease because the doctor there kept I felt pushing us off. Let's push him off to an adult doctor now. Let's push him off. Let's push him off. What do you say? Well, he can be seen back in the Lehigh Valley. What do you say? Okay, so that's what we did. Well, February 21st, at the age of 18, we consulted with an adult nephrologist. And at that point, he was referred to a cardiologist for a workup. He was showing signs of kidney failure and told that dialysis is forthcoming. Well, that crushed me, that. My baby boy, he's still my baby boy, has to go on dialysis, no way. In November, he was referred for a PD catheter placement. January 18th, 2024, PD catheter was placed. January 29th, 2024, he was put right on dialysis. We chose PD dialysis. He's young, he's active, so that we figure was the best part for him. So we were referred by St. Luke's University Hospital to Temple for a new kidney. He was placed on the kidney transplant list for a cadaver kidney. I believe we had seen Dr. Chavin. I think he was the first doctor that we had seen, and he had said, he's definitely a candidate. His microsite was created through the National Kidney Registry. He got the personalized business cards that we could give out. We could hang places. We were searching for a kidney. But still, 5 to 7 years, I couldn't do this. So I thought, okay, let's call other transplant hospitals. I took him to Hackensack Medical Center. He was placed there. Theirs was 5 to 7 years. Then I heard of University of Toledo Medical Center in Toledo, Ohio. Him and I called, took a ride out to Toledo. We were there 4 months. 4 months, they told us. I said, what do you mean 4 months? So, okay, we did the workup the next day, the all-day thing. The doctor walks in, the surgeon, and he goes, hi, he goes, I'm Obi. And what do you think of? Obi-Wan Kenobi, right? This guy was awesome. He goes, I'm Obi. He goes, have you tried finding a living donor? Yeah. Not really. How do you ask somebody for a kidney? How do you do that? So I thought, no, really, I don't feel like I did the best that I could. And he's like, that would be the best bet. He's young. You got it. He said, I can get him transplanted. He said, but you really want to find him a living donor. Okay, so went back home. Also listed him at Lehigh Valley Hospital. Toledo did call us and offered us a cadaver kidney. And they said, you can be picky. You can, In fact, they advised us to be picky. They said, you can say no. So we said no. December 16th, 2024, it's 3 o'clock in the morning, I can't sleep. I thought, I got to do something. So I went, and 3 a.m., I created a post. I asked the moderator of our local Facebook if I can, post this, because I'm seeing everybody's online looking for, presents for their kids. They're looking for, the food. They're looking for all these things. I'm like, my kid needs a kidney. I need a kidney. So I reached out to her. I said, my son needs a kidney. Can I post this? She said, absolutely. I posted that. A couple days later, Lehigh Valley News picked it up. The reporter came, he interviewed us. We created a kidney for Aiden@gmail.com because the gentleman advised us we should really do that so that people can communicate back and forth with us. January 4th, 2025, our local news, WFMZ Channel 69 News, called and wants to do an interview. We did the interview with Channel 69 News. So it was really getting out there. January 2025, Aiden receives a phone call from Temple that they have a kidney for him and that surgery was scheduled for January 29th, exactly 1 year from the date he started his dialysis. It's like, yes. Well, he was having gastrointestinal issues. We said something, they revoked the kidney. Let me tell you something. That was just a kick in the gut. That was awful. And I have to say that was the first time I saw my son was actually angry. And I was fit to be tied. I understand why. They're not going to transplant a healthy organ into somebody that's possibly sick. He was having a colonoscopy 2 days before that surgery. And I'm thinking, well, why can't you just wait? Let's see how the colonoscopy turns out. They don't work that way. Well, that was difficult. So January 27th, they did the colonoscopy. May I say, it was all fine. There were no problems. Most likely, all of his gastrointestinal issues were from the drugs, all the drugs that he was on, and the dialysis. He was dialysizing at night, and then he was also carrying dialysis in his gut all day. So he was on a double whammy here. He was never without it. So February, we received a phone call from a possible donor reaches out to us. They said, I'm testing for your son. And it's like, oh my gosh, really? Thank you. We connect, we talk to her, and incidentally, he was having other issues. His PTH levels were very high. So we are sent to another surgeon. And they said, you know what, these PTH levels are very high. We're going to have to take some of those, the parathyroids out. We have 4 parathyroid glands. They removed 3.5 glands out of Aiden. It's like, wow, I guess it's good that he didn't get that kidney because that would have made that kidney work hard. I didn't realize this. Again, this is God's working his miracles, because if we would have gotten that kidney, you never know what would have happened. We weren't really monitoring that PTH. So he had that surgery March 13th. Early May, again, she hadn't heard from Temple. We hadn't heard from Temple. We didn't know anything that was going on. We're just moseying along our way. Early May, our donor, our possible donor, lets us know that Temple released her because they found a better match. I said, a better match? What are you talking about? And she goes, I don't know, but surgery scheduled for May 21st. Knew nothing. Got on the phone, called Temple. Now again, we shouldn't know these things. And I called and I'm like, what's going on? What do you mean you don't know? No, we have no idea. Again, we had become very good friends with this donor. In fact, she went from donor to really support. She was a very good support. She's like family to us now, because when he had his transplant, she's been there for us a lot. She's like, you ever need, you need anything, I'll take him down. My car knows just how to get to Temple real good, because I found out she was down there like 6, 7 times. Never knew this. We didn't know that part. And that's why this summit is nice, listening to what the, recipients and the donors go through. We didn't know. I didn't know the ins and outs. So May 21st, Aiden is blessed with his new filtration system from an anonymous donor. The person didn't want to reveal who she was. We think she's a she. We don't know. I'm just saying she. Just by the letter that this person wrote was very endearing. They didn't want any accolades. They didn't want any. They didn't want anything. They just wanted to do what they, felt they could do to help our son. And I hope and pray that one day we will know who this person is if this person decides. But we are so thankful for, what we, the gift of life. So there's a list of our resources. We stayed at, again, the Ronald McDonald House, Gift of Life, Howie's house. That was where we had stayed during his transplant. Make-A-Wish Foundation, NKR, the National Kidney Registry. My husband had created a Facebook page, Faith Over Fear, Aiden's Transplant Journey, because we had so many people that wanted to follow his story, and how do you get it all out? They see it on the news, they want to know what's going on. So we created a Facebook story, and again, local churches, community support, that's the most important part. And be your own advocate. Don't sit back and wait. And don't lose faith. Because if you lose faith, you're done. You're done. Oh, my husband's telling me. For any pediatric people out there, when I got to not Montefiore, when we had taken him down to Hackensack asked us if Aiden had PED points, and I said, and they looked at me and they said, if you don't know what I'm talking about, then he probably doesn't have PED points. I said, well, enlighten me. So if Aiden would have been referred before the age of 18, he would have been shot to the top of the list. So let's just say I was very unhappy with CHOP. And I'm sorry, I'm calling him out, because why didn't they tell me this? Why didn't they tell me this? Why didn't they refer him? Why? So PED points, peeps. If anybody out there in cyber world, PED points. If you have somebody young, find out. Ask questions, ask for, resources, look it up. But there is something called PED points where it doesn't matter. If he was needed it at 21, he would have had all that time, and he didn't. He had to start out because when they finally said he did need it, he was, 19, 20 years old. So that is very, very important. That's it.
Thank you. Thank you. Any questions here for Melissa? Thank you. Thank you all. We have Dr. Chavin. We have Ryan. We have Carly, Jamie, everyone. This has been fantastic. Thank you all for staying, for joining us. And I want to just again extend real gratitude to Wood Temple for doing this together with us. Ryan, can you stand up? And Carly. You have Carly. Thank you. Want to also really, Jamie, thank you for doing all this. Leslie. Okay. And I really want to also point out thank you to Phil Keogh, who's sitting in the back, for allowing us to do all this. Really, really great person, and we value you highly. Thank you to all the community managers. Thank you to Transplant Life. Really tremendous work for what you do with us, and all of you virtually as well. I really want to thank all the speakers, the Temple Health team. I mean, you are amazing, really, really amazing, every single one of you. You've really shown also, someone said to me in one of the breaks, it's incredible what a large team, I think it was Carrie, from the PCA team, what a large team is required for a transplant, right? And it really is tremendous. And so as transplant recipients, we obviously have to deal with a lot of different constituents, and as a care partner, you have to keep track of that too. So it is work, but it is fantastic to know that so many people care. So thank you to everyone who is involved in this community. And I want to just point you to where you could get help, of course, from other peers as well, right? And Transplant Life and Kidney Life are built exactly for that, right? That is a resource that is there all the time, always someone around to talk to you. So please join, and if you would also like to continue to track and symptoms, and as Dom really articulated, Transplant Life 365 is another resource for all of you. I think you have the information in front of you. And of course, finally, I want to thank our sponsors again, really tremendous, and not only for what you do all the time, but also to those sponsors who were here and presented and really shared in a very, I think, unbiased way, you know, the value that you bring. And your therapy might be one of several, and we want to point that out. So it's been a wonderful day, and I want, of course, to offer to all of you continue to converse and to continue to share. We do have time outside as well, but I hope that many of you shared connection and can continue afterwards. At least I did. I learned a lot today, and I want to talk to many of you going forward. So thank you, and have a wonderful rest of the day and week.